Welcome back to the Given Voice podcast with me, Issy, and Nathalie, my lovely co-host.
Today is our last episode of the Day in the Life series.
We will be joined on Teams by Aarti Panchmatia, who is a speech and language therapist working in mental health, split between level 1 neuro rehab in a neuropsychiatric unit and adults of working age in a mental health unit.
Aarti will be sharing with us the world of neuro rehab and mental health, what the two parts of her role entail, and what skills are needed to work in this area.
We hope you enjoy it.
Hi Aarti, thank you so much for joining us virtually on the podcast today.
Thank you for having me.
It's so great to have you here with us.
So to begin with, I thought we'd love to know a bit more about your career progression. So could you tell us how you got from your first role as a newly qualified therapist to your current role?
Sure. My first role was in adult acute hospital outside of London. It was working with adults, like I said, and in that role, it was actually only communication. So the trust that I worked in, Band 5s, only did communication. So the first 6 months I worked on just acute wards, so that's everything other than stroke. So it was older people's medicine, acute neuro and neurosurgery. There was a little bit of ICU and respiratory and cardiology as well. And then I rotated onto stroke. So after that role, I did my dysphagia training in that role, and then I stepped into a Band 6 rotational job in the same trust. And then I went through stroke again as a Band 6. I did acute neuro and neurosurgery rotation, a general medicine rotation, and a bit of my cardiology and respiratory before I left for a new role. And then I did a little bit of locum work in some mental health units up in Dudley and Wolverhampton and other areas of the Midlands. And then after that, I moved to London actually, and that's where, Issy, you had your student placement with us.
Yeah.
We were a brand new service called the Rapid Access to Acute Rehabilitation, or RAR. And we provided level 1 neuro rehabilitation. So that is intensive daily input for people with acquired brain injuries or spinal cord injuries. And NHS England launched these sort of schemes where they wanted to increase the number of level 1 neuro rehabilitation beds available. So each quadrant of London, I believe, had funding for like 8 beds. So yeah, that was really exciting because I hadn't done pure neuro rehab before and learned a lot during that placement. A lot during that job. I did that for a year and a couple of months, I think. And then I'm now in a new job. So I started in September
at the Lishman unit. So I work with South London and Maudsley Trust. And my job is split between a neuropsychiatric inpatient unit where we have brain injury and functional neurological disorder pathways. And then the other part of my role is working with patients with acute mental health difficulties, and they've been admitted to different types of mental health units across the trust. So in my role, I work with the working age population, and there are other speech therapists that work with the older adults. And some of that can include like the National Psychosis Unit. It might be like the Mother and Baby Unit, general acute mental health wards, as well as those specialities and a few of the other specialist services as well. So yeah, a really varied role split between both neuro and acute mental health. But it's interesting because they're both quite similar in some ways.
Oh, wow. And what is functional neurological disorder?
Yes, that is. I've actually written it down because I want to make sure that I'm saying it properly. So it's a problem with the functioning of the nervous system and the way in which the brain and the body send and receive messages. If you think about someone who has had an acquired brain injury, there is some sort of structural damage that has occurred, or a spinal cord injury. They've had some kind of either external or internal damage that has occurred to the actual structures or the organs. Whereas with functional neurological disorders, it's to do with the way the functioning is, the way it moves, the way it works. So it's the kind of disruption in the way your body and brain communicate with each other.
Okay.
Is the best way to explain it.
Maybe this is a hard question because I can imagine your days and weeks look very different. But what does a typical day or week look like, as much as typical can be?
Yeah, you're right. It's really difficult to kind of talk about what your week looks like. As you can guess, it is really, really varied. We have so many different pathways that I'm part of. So, you know, mixture of patient contacts from different pathways, but also a lot of meetings. We have ward round days during our week, and there's ward rounds for people on the FND pathway or organic brain injury pathway. When they come to the ward round, it's the multidisciplinary team. We feed back how and talk about progress, kind of discuss where we think someone is, any assessment results, just so everyone like having a really good conversation. And we invite the patient to come along to those meetings as well, so it's their time. For them to ask questions, for them to be to make sure that they are clued in on the care that they're receiving. It's a sort of that dynamic process, I guess, so that they are part of the process of rehabilitation. And it's particularly important in mental health services as well. If you think about traditionally, the power balance was people with mental health conditions and things being done to them. So the idea is that people with an illness or a difficulty are empowered to take part in their own care and make decisions. We have meetings for formulation, so it's where the whole MDT, including psychology and also nursing staff and doctors if they're available as well. It's where we come together and we pull lots of information about that person. So we look at not just like the pathology or what's happened to them from a medical perspective. We're building a holistic profile. It's a bit like all the pieces of the jigsaw puzzle coming together, and we all have different snapshots of that. So we're trying to understand really what the current presentation is and how that might have come about, as well as thinking about like, okay, what does that mean for someone in terms of their role, their life, their rehabilitation, future discharge, that kind of thing. And then we also do goal setting with patients during the week. So patients will come along and we'll discuss how they're going, and all of our rehabilitation is goal led. So we try and do interdisciplinary goals. So it would be like if someone was said, I just want to go outside and go for a walk, thinking about, okay, as a speech therapist, what's my role in that? Is it, helping them plan a journey and plan a route? Is it helping them navigate communicating? Is it actually, okay, you want to go outside, and is there something you want to do on the way? Do you want to go to a coffee shop and have an interaction there? So we all feed into the patient goals. Also lots of patient contacts, so we do one-to-one sessions, joint sessions with different members of the MDT. We might do groups, so we're currently like a project group on our ward, so our patients were planning the ward Christmas party, for example.
Oh wow.
Yeah, that was great. Yeah, real mixture of things.
Wow, your role sounds so varied and so interesting, and it's amazing to hear how much the patients are so in the centre of your care and so involved in everything. How does your current role differ from your previous role in RA?
In loads of ways. So operationally, RA was a new service that we had set up, but had a senior speech and language therapist with me. I am part of a team with senior speech therapists currently, but on the Lishman unit, I take responsibility for the speech therapy caseload. So a lot of learning in terms of, what I want the caseload, not the caseload to look like, sorry, what I can provide as a service, what would be good, what skills I have, and upskilling myself. I'm a lot more autonomous in my work right now because of that reason. Things like timetabling my week, deciding how much or which meetings to attend, where to put my patient contacts, that kind of thing. And from a clinical perspective, the environment is completely different. So RA was still in a large acute hospital, and that's all I've ever worked in, really, apart from when I did locum work. So this is the first time that I feel like it's a little bit further down that journey. So still inpatient work, but it feels like it's going on that spectrum towards community. So it's really, really different from RA in that way. On RA, our patients are still medically unwell, whereas ours are medically stable. But our patients have acute mental health needs, or at least part of my role, the working age part of it, I could be working with patients with really acute mental health needs. There's still an acuity to part of my caseload, compared to the brain injury side of things and the FND side of things. So there's a lot more difference, like a lot of having to learn the language of mental health is it's completely different. It's what community services are available, how they're structured, things like what do different antipsychotics do to the swallowing, to communication, to cognition, like a very different kind of learning, but still a new language.
So are the patients that you see right now in your current role, do they stay with you then for like a longer time?
Yes and no. So it depends again on which pathway they're on. So for our FND patients, there is a set time period. So they would come for an assessment period for a few weeks, and then if they want to continue for rehabilitation and we feel it's appropriate for them to continue for rehabilitation, they then have rehabilitation for a few more weeks, a bit longer than the assessment period. So they have very set kind of pathway. With our brain injury patients, on average 12 weeks, but I suspect it does actually go way more, because a lot of our patients have really complex social situations and circumstances, or sometimes following their brain injury, what was there before isn't appropriate now. Some don't have the social infrastructure around them either, so a lot of things need to be put into place, and they end up on our unit a lot longer. I mean, it's not just a brain injury unit, it is for people who have co-occurring mental health needs as well. So we're providing mental health rehabilitation as well as neuro rehabilitation. So it might be that because of that, they need a longer period for work to be done. On the working age side of things, I might not see a patient for as long as that. I might only see them for one contact or two contacts. They might be admitted into acute ward initially and then stepped down to somewhere else, or then managed in the community. So it really depends. But RA was only an up to 6 week service, so it's very different.
It must be nice to have some patients that you see over such a long time, to be able to build that relationship and to really get to know them and be involved in their care for a long period.
I've actually learned how important that, like you just said, the relationship. I'd say particularly within mental health and also neurorehabilitation, but you do have to really build a strong therapeutic relationship. That person has to trust you on all the pathways. That's really important. And I took for granted, on acute, I used to, like, my first kind of, we think about the phases, like that first big trust that I worked for, sometimes within one contact you would have to build rapport, do your assessment, provide intervention, give your recommendation, like tie it all up in one and then walk away. Particularly on general medicine wards, that kind of thing, where you might only see that person once, maybe twice maximum. Then on RA, you've got 6 weeks, so your first week might be rapport building, information gathering, assessment, and then jumping straight in. Over here, I feel like you spend a long time on that beginning rapport building and information gathering. Initially I think I was trying to go really gung-ho, and it doesn't work. You need to build a good relationship. You need to really understand, a bit like the formulation, you need to really understand what has happened, how are we here, what are the pieces of the puzzle, how are things manifesting, and what does that mean now and for my role in their input right now. So you take time.
So it sounds like, in terms of the patient's journey that you've talked about, it sounds like your role at the moment is more towards towards the community team, whereas before in RA it was perhaps closer to acute. So what would the actual journey be then? Would someone come from ICU to perhaps the acute team, then to RA, then to your role now? Or
I mean, that would be lovely, wouldn't it, if someone was able to follow that? Yeah, not always, but
yeah,
you do get patients who, on the brain injury pathway, they will have maybe been in ICU or maybe not been in ICU, might have been on an acute medical ward, because they might have had a traumatic brain injury that's led them to ICU, or a spontaneous bleed or something. But they could be someone that's had a tumour or inflammation of the brain, or another trauma that has not quite resulted in ICU. But yeah, they could be in that really acute place, and then on the acute medical wards, if they're lucky to have gone through a RA service. So yeah, if they did go through that process, they would have got, the rehabilitation journey would have been kick-started. For many people, so RA isn't in every single hospital. It's not all over the country either. So many patients won't have had that. So they might not be receiving intensive input whilst in hospital. So we have to be mindful of that when someone comes to us. And it's no one's fault. It's just that services are really stretched. People are constantly coming into hospital. Sometimes, so then those patients would come to us in a rehab unit or to other level 1 rehab units. There are level 2 rehab units as well. So according to that person's needs, the level of rehabilitation that they require. From us, they would then either, maybe they need to have a nursing home or care home placement, supported living, or going home, but with, maybe some care or onward needs. And then we would refer to the community teams if required. So that's sort of that brain injury pathway. But if we're looking at the working age side of things, that could be someone that just is experiencing psychosis. They've been admitted to hospital, and psych liaison service has seen them and said they need an acute mental health ward. So then they would come over to our acute side. So we might see them when they are very acutely unwell. It really depends.
Yeah, it does. It really varies. So I suppose then often the patient would have already seen by perhaps another SLT before coming to you.
Thinking about our brain injury only patients right now, most likely they would have seen a speech therapist for at least a couple of contacts. And just to quickly touch on with the FND pathway, we might not, people might not have ever met a speech therapist before.
Wow, thank you. No, that's really interesting. I think it's so, I've not had a placement in any kind of neuro rehab, so it's interesting to see how it all fits together.
So your new role involves working with adults with mental health conditions. Which mental health conditions do you typically see in the unit, and did you need any extra training for your new role?
Yeah, we see lots of different mental health presentations, and lots that I have yet to see. I'm guessing I've just sort of started. We might get the organic mental health presentations, so things like dementia related, Parkinsonism related, Huntington's, due to a brain tumour or brain stroke. So there's been some kind of damage which has led to mental health difficulties. Then you've got lots of other conditions, people with severe and extreme anxiety, severe clinical depression, eating disorders. I haven't worked with anyone with eating disorders in this job. I have previously, but that's something that we're hoping to develop a lot more in this service. People with schizophrenia, bipolar disorders, and people who are in acute psychosis as well. So in terms of kind of upskilling and training, so I have a master's in psychology, which has been helpful for this role. Even for things like understanding sleep, understanding things like how antipsychotics work. That's been really helpful, but I wouldn't say essential by any means. And I'm also currently studying on a counselling skills course. So so I did my level 1 and level 2 last year, and now I'm doing a level 3 course, and that I would say has been really helpful. because also I guess some of our role, we might feel like we have to provide a solution for people, and we're the therapists, here we go, let's solve things. But actually a lot of what I'm learning on the counselling skills course is very much just about holding space, helping someone, that it's just that person exploring it for themselves, and you're just part of that journey, really.
Yeah, that's really interesting to hear. We've had a couple of counselling skills lectures in uni, and our lecturers have been talking a lot about that we don't need to provide the answers, and actually being a good listener and just being someone that they can open up to and share with is so important.
Yeah, they're right.
Yeah, I agree with Izzy. I feel like it sounds simple, doesn't it, just listening, but when we've learned about it on the course, it is so difficult, isn't it, not to just give advice. No, thank you.
But yeah, I would say you don't need specific training to go and work in mental health. I think we already have the skills. You can upskill along the way, and that's going to be really useful. But if there's anyone who is interested in mental health but doesn't feel qualified or doesn't feel like they know how to go about it, I'd say that it's really worth trying. And you don't need to have done a psychology degree or specific mental health studies or anything like that to work in the field.
Also, wondering, you've mentioned obviously a lot about the MDT and the multidisciplinary team. I wondered, which members would you say you work with often, and what do you think the benefits are? I know there's many.
I love working in an MDT. We also don't really just work as an MDT, we work in a really interdisciplinary way. So that means we don't work sort of side by side and all doing things together. We sort of really weave into each other's sessions. We really kind of, I guess you slightly overlap with each other's, but still within the scope of your own profession. So yeah, I really enjoy that. I do work with all of the professions. So I'd say the most that I work with are the occupational therapists and clinical psychologists and assistant psychologists. There's a lot more overlap there, but even with physiotherapy colleagues, because if you want to take someone out for a walk, you might go with your physiotherapy colleague and be practicing walking and talking at the same time, for example, and voice work as well, that kind of thing. So yeah, lots of work across all the disciplines. The benefits, like I've already spoken about interdisciplinary goals. So if the person has a goal of going to the shops, it's not just looking at it from what is purely, oh, that's not a speech therapy goal, that's a physio goal or an OT goal. No, it's really thinking about what's my role within this. You get a really holistic view of the person. You get to see them in different settings, like you get to see how competent their communication is in different settings, or what barriers there might be that you may not have realised in your small clinic room or by their bedside or something. Actually, when you're out there in a busy hospital corridor or out there on the tube, like, what are the barriers here? So yeah, lots of settings. Piecing together everyone's bit of information leads to better understanding, I guess, that better formulation of the current presentation. I find different colleagues have better rapport sometimes with different patients, so that's also, it's really helpful actually. If you don't feel like you and a patient are really clicking, or the relationship isn't really working, sometimes it's really helpful to go with the person who it is working with.
Really interesting, thank you. And it might be a silly question, but when you've talked about the goals that you create together, so obviously they're quite functional, like for example, if you're going to a cafe or getting directions somewhere, would you ever go to a cafe or work outside of the sort of the centre?
Yeah, that's exactly what we do. Someone, they want to go to a cafe, let's go. Yeah, I mean, not everything is achievable. If someone says like they go to Hawaii or
that would be great.
And for example, I know for one of our patients, he wanted to go to a cinema, and our colleagues, they weren't able to go and see the film with that patient, but they practice, going to the cinema, looking up the times, practicing the stairs, sitting, measuring the chair of that, and then practicing in the ward. So you try and as much as possible, try and do those goals that are functional, and then might be that then a family member is able to take over the actual doing the cinema bit. But
Yes.
yeah, as much as possible, like we take public transport with patients, and we
Oh wow, that's amazing. Really, really cool. Super functional.
Yeah, it's so interesting to hear about like this much more functional side of therapy, and it sounds like you then do work a lot with families or other carers. Is that so?
I do, yeah. So often in neuro rehab, you have like a key worker role. A member of like the MDT might take, and they're sort of the point of contact between family and the therapy team, I guess, you could say, or the ward. Not strictly, you know, we all have contact with family members, but so I take on a key worker role for one or more of my patients. You also, really work really closely with families, information gathering. Sometimes that person isn't able to provide all the information, so kind of checking or establishing it with family members, but also getting their perspective is really important. I've also recently really recognised the value of friends as well, including friends in the rehabilitation process. We're probably different people with our friends than we are with family, if you think about the way that you change between those two.
Very true.
So I guess trying to involve them in care is in the rehab process, training them up, you know, practicing strategies, getting not just their opinions, but also getting them involved, because they're the people that are going to be interacting with that person long after you've gone. And I guess also decision making, you know, they're going to be important parts of any important decisions around, you know, whether that's eating and drinking with risk, whether that's peg tubes, whether that's where does someone live, or how do they want to live, what are their values. They're the ones that know that person's values and lifestyles and what others would be. So really important.
And I wondered, Aarti, if you could tell us what your favourite or most memorable moment has been on your role, or perhaps on any of your roles to do with neuro rehab.
I think my most memorable moments have been times where things go a bit wrong. Times like people trying to run out of hospital and us trying to support them back in. Always very entertaining. And I think actually my favourite is if someone comes out of that process and then you talk about it afterwards with them, and they're like, no, that wouldn't have been me. I would never do that. And you laugh about it with them. I've had some really, really great moments where people have been able to tell family members that they love them, or write down that they love them. You know, seeing that kind of, you know, coming together of people and that moment of interaction has been really lovely. But unfortunately, the most memorable are when people are trying to escape, and I'm trying to navigate that.
That's so funny. They're excellent.
It's never a dull day in neuro rehab. Promise you that.
No, it definitely doesn't sound dull.
No, definitely not. And finally, we'd love to ask you what your top tip is for any student SLTs listening.
Sure. Carry crib sheets on your placement. I think, and I felt this too, like placement is not a test. You know, like your placement educators, they really want to support you, they really want to help you, but they also do have to check that you are understanding. So that's why they ask questions. But honestly, I really love it when a student pulls out a bit of paper and is like, hang on a second, I've written this down. It's not a memory test, basically. Like, you know, that's you have exams for that. You know, we're not there to test you on like, what have you remembered that I told you 7.5 days ago that I need to recall right now. Like, you know, carry, you know, if you've got a little framework, I'd recommend as a crib sheet. So, you know, thinking about a communication profile, like understanding expression, speech, voice, like all of the boxes, non-verbal, you know, jotting things down. It really helps you to gather your thoughts, you know, carry those kind of crib sheets. Think about like, okay, I'm seeing a Parkinson's patient. What are the key features that I know about them? Here's my crib sheet around Parkinson's. I used them not just as a student, but I used them massively in my first, and even like, I mean, I still pull out crib sheets now and then, but definitely in my first year of working, please carry those with you. And I guess if you're looking for a rotational role as a student right now, I mean, they're really hard to get, particularly in London. But just think about your transferable skills. Like if your first role isn't rotational, or your first role, or you think, oh, I now want to apply for neuro rehab, but I've only ever done general medicine, or, you know, I've only ever had older people's medicine or pediatric clinic. Really think about like, but what skills have I got from those?
Yes.
So like, you know how to take a case history, like, you know how to clerk a patient from medical notes, you know how to have a phone call with family members. Like, what are the things that you do know? Because the rest of it is just knowledge, and knowledge is something you can upskill on. You can get you know, from literature, from reading your textbooks, from going back to your notes. Like that's all stuff you can do. But like, I think those skills based things are harder to acquire, but they're really transferable.
That's very true.
Thank you so much, Aarti, for coming on the podcast today. It's been so interesting and I've learned so much.
No, same. For someone, like I said, not been in a placement like this, and I feel like I've had a placement like it now. So thank you so much.
Yes, thank you so much.
We hope this episode has sparked your interest and has revealed another really interesting career path that can be taken as an SLT.
If you enjoyed this episode and want to hear more about other career paths, check out our other episodes in the Day in the Life series, in which we've spoken to SLTs working in deafness, voice, critical care and youth justice.
We really hope you've enjoyed the series. Stay tuned for our last episode in the UCL Communication Clinic series, which is also our last episode as hosts.
Thanks for listening and see you next time.
Bye!